this very important conversation on something that is very important and has become even more important in the context of population aging, but does not receive the kind of attention it should. So very happy that today we are discussing about it, and we all know that it's very important. It's as important as physical health and well-being, but it generally doesn't get that kind of importance. So we thought that today we will use this afternoon very usefully and talk to a few people who are experts in the field, who will touch a wide range of topics and subjects and subsets of the important issues like media attention and how media portrays the elderly people. How does it impact them? How does one take care of elderly people who are suffering from dementia or are at the risk of getting a problem? uh, we'll also look at how communities can play a very important role, because that, as an organization that works for the elderly, is very important for us to understand how we can intervene at community level and make sure that elderly are not just physically fit and fine, but also have a very, very fulfilling lives. So it's very important that we touch on this topic. And with this conversation, we also would like to draw the attention of policymakers and the other important stakeholders like educational institutions and the corporate sector to see that mental well-being and mental health and brain health is, it's never too late to start talking about it and taking care of it. And it's almost like a social investment that we must all think about seriously. So this is a webinar in that series. So we intend to do a few more, but this is the first one, and I'm very happy that the experts have given us the time. So very warm welcome to all the experts, and of course to the chair, Dr. Indra Jayaprakash. She's a well-known name, and she has been working with us and in the field on gerontology and psychology for a very, very long time. Personally, she's a mentor to me. I actually learned everything about aging and the psychology of aging from her. So very happy that she could be with us today, and also Swati, who is she's a very dynamic and young scientist who's working with us currently as a researcher, and she's trying to see how technology can intersect and help the people with dementia and their caregivers. So these are quickly we will show you two slides which will uh, tell you about the we have it's very difficult to introduce such people who have got a long list of achievements, but we have tried to show you some big part of it. And so very warm welcome to you, Dr. Indra Jayaprakash, and over to you.
I joined Dr. Amrita in welcoming others. Everyone agrees that longevity is a very empty phrase if it is not accompanied with good health, good mental health, and functional competence. Brain health basically is a composite of how the person functions in different areas like physical, sensory, motor, cognitive, social, and emotional. Maintaining brain health and that through maintaining good mental well-being throughout life course requires a very proactive approach that requires input from several disciplines as well as involvement of all the stakeholders. So optimizing brain health is very is a priority because it impacts other areas of our well-being. Now, in recent years, because of demographic changes, as well as because of research in cognitive science and gerontology, we've accumulated large amount of data about aging and the aging brain. However, we see recently a paradigm shift with a change in the way we look at the aging brain and cognitive decline. See, I will just highlight only 3 trends here. The first trend is we are moving gradually away from deficit decline disorder sort of model. In the sense, it's not that there is once a person is old, it's not that the total decline, but there are diverse trajectories. And with the humbling acknowledgement that we really do not know much about the amazing thing called brain and the neuroplasticity and its ability to regenerate, rewire, and all. So now the shift is more on what can be done about neuroplasticity rather than. The second trend is health in old age is not just biology and genetics, socio-cultural practices, views on aging, ageism, and the media images that people internalize will affect not only their self-esteem, their health, even longevity. So there is a need to challenge narratives and question these scripts and rewrite. The third strength is an optimistic view supported by research that yes, we can improve brain health and we can prevent cognitive decline. The sense, even at a preclinical stage, some diagnosis is done or early detection is done, we can prevent lots of damage. And there are lots of things can still teach in old brain with tricks. So all this sort of information is coming in from different sources. It is imperative that such information is disseminated. People should be told about the research-based information, evidence-based facts, so that you can demystify or you can challenge the myths and stereotypes that color our lives, because knowledge sharing is a very powerful tool of advocacy. We have to keep people informed about the latest advances in research and that other aspect. And this is what today I think HelpAge is attempting to do. We have brought together four eminent luminaries who are experts in their who are very academicians and researchers, and they not only bring their research wisdom into this, they also are very passionate about the topic they're working on. So let us welcome these four people. We have with us Dr. Claire. I think a brief CV of them will be shown. Dr. Claire, who is a community psychologist, Dr. Shan, who is a media psychologist from where is UK.
Hello.
She is the founder of Wellbeing of Aging Women at Work International Collaboration. And next we have Dr. Sharon is a media psychologist, and her work focuses on studying the influence of media and social platforms on several global issues. Then we have Dr. Ashima Mehra, who is a professor of clinical neuropsychology, College of Medical Sciences, Delhi. Her work on dementia and cognitive retraining are very well known. And our last speaker is Dr. Kirti Rancho, who is a neurologist, Joburg, and she is the founder of Memorability and also a co-founder of African Community Brain Health Initiative. Before I request for I request these experts to tell us about their work. I request Dr. Swati Bhatte to brief us about the context of this program. Swati has curated this program. She herself is a clinical psychologist in Atlanta, fellow for equity in brain. Over to you, Swati.
Thank you, ma'am, for such a wonderful introduction. And I would say good afternoon, everyone, and a very good morning to our speakers joining us from UK, Sharon and Claire. And I believe Kirti is able to join. I can't see her. So probably in a minute she will join us. It's a pleasure to welcome you all to today's session on brain health and aging. So brain health as a concept has gained increasing global recognition in the recent years, particularly through the work of WHO, like the Global Action Plan on the Public Health Response to Dementia. And there is a global growing emphasis on healthy aging. So it just goes beyond the mere absence of a disease. brain health basically a kind of a concept, basically a kind of a entity which refers to an ability for an individual to maintain an optimum cognitive, emotional, behavioral functioning and across the life course, like which contribute to an overall well-being. And I believe that a lot of my patients and a lot of my family members who are aging, my parents, my grandparents, they and many individuals like them begin to reflect on a critical question as they age, that we are living longer, but are we truly living well? And that's the question to ponder upon, and that's what brain health is all about. So I believe that the heart of a healthy aging lies a brain health, and yet which is often overlooked or under-recognized until changes become more overt and begin to impact the daily living functioning and the independence. So it I believe that it represents a universal challenge across the countries through varying degrees in terms of awareness or stigma or gaps in terms of care and preventive interventions. So I believe that today's discussion is both timely and necessary. So because it offers us an opportunity to move beyond viewing our brain health solely through a disease lens, instead adopt a broader perspective which is focused on prevention, promotion and a life course approach. So I hope today's session will not only deepen our understanding on brain health, but also inspire, and actionable ideas for research practice and, and policies and other practices. So without a further delay, I would like to invite our speakers to share their experiences and insights. So over to Claire and Sharon.
Thank you very much, Swati. Thank you. It's truly an honor to be part of this very, very important conversation about global aging and brain health. While we wait for the slides to come up, I can start introducing the topic and what we're gonna talk about. I don't know if it shows for everyone. Yes, fantastic, very good. Thank you very much again. And the title of our talk today is New Tricks and Old Tropes. And basically what we're trying to do here is to look at the contribution that media and technology can play in fostering or indeed hindering our experience of aging in a global population. So we're gonna start by, if you can go back to the previous slide, please, considering this picture. It's quite important. It's a picture taken from a book on global aging that presents an experiment that has been run years ago in China, where they delivered robo-companions to Chinese population living in nursing home, and they were studying whether and to what extent the elderly would interact and enhance their well-being by interacting with these robots. And this is not a new thing. Actually, a few years ago, I was invited to an event at the Royal Society where we were working on questions surrounding, can we use technology and robotics to help us overcoming the challenge of the shortage in nursing staff in the UK? And they were saying, with an aging population, we need more and more nurses, we need more people looking after the elderly. Can robotics be the answer? And so we can see how in a global population where our experiences are increasingly mediated, where we are really interacting with technology and media to communicate, etc., we are turning to these tools to find solutions to problems we are facing. And the question is, to what extent can media really be helpful and how? And this is what we're going to discuss today, looking at the role played by media in the co-construction of aging as an experience in the global population. Claire Edge, my colleague, will start with the next slide, talking about well-being and aging and how media use can plays a role in that aspect, in that respect. Thank you.
Thank you very much indeed, Sharon. Thank you ever so much, everybody as well. It's wonderful to be here. And if I may ask those who are able to use your mobile devices to use the camera to scan the QR code, please do so to take you to menti.com, which hopefully this is technological advancements that I'm slightly nervous about at this present moment in time, but I'm hoping that this will work. If it doesn't work, as an alternative, you could possibly share your thoughts in the chat. I've got two questions, if I may ask you to engage in. Firstly, in relation to what you think in terms of a number that would categorize when we're older. So when are we older in terms of a number? When are we old? And then the second question I will outline in a moment. So just consider that firstly, if that's okay. That should be live and it should be working. I'm getting numbers through, so that it is working, which is fantastic. So we've got 60, 80, some variation so far. 50, 90, when you retire from work. So keep those coming in if that's okay. And for those of you who've done that, moving on to the next question, I'm just going to ask if you can consider a word or perhaps a very short sentence to describe how society views growing older. What ideas does society associate with growing older and older age? That's the next question. And for those who are still doing it, no age to describe old. I like that one. And that's not one I've ever had before. So this is great, fantastic, 65 and above. Some variation, but generally the consensus is over 50. So the next question then, if everybody's able to get on to the next one, which is, what words or ideas do we associate with growing old as a society? Fantastic. We're starting with the positive here. I like it. So wisdom. Burden. Yeah, so I was expecting to see some more negative sort of associations, because society does unfortunately have those, but I'm really pleased to see lots of positive associations. We've got experience and wisdom, experience again, Medicare. Yeah, is that perhaps associated with burden? Any other ideas or words? I'll just give you another 10 seconds and then I'll move on to the next slide. So in terms of the definition of when we are older, so first of all, I'll focus on the kind of functional decline definition, and then I'll talk about the different definitions in association with the elderly, and then also the term geriatric. And then finally, I'll focus on the definition in relation to the workplace, because my research focuses on the workplace. So that's the definition that I use. So the World Health Organization classifies the start of functional decline from age 45. We didn't have any numbers that low, thankfully. And in terms of elderly, there's variation as well. So 60 and 65 have been considered as elderly, but also 65 has been considered geriatric. And then in terms of older workers, again, there's lots of variation from age 40 to 75 plus, but the EU and others tend to use 50 plus in the categories that are outlined on the screen. But actually, as people have clearly outlined, which is fantastic to see, actually there is a lot of subjectivity to this. And the research shows that our perception of when we grow old does indeed change as we grow older over the life course. Next slide, please. So the next slide hopefully illuminates that there is kind of no arbitrary cut-off point to growing older. And these women over 50 in the pictures, there's a fantastic resource space with lots of cultural context depicted in this image library from the Centre for Ageing Better, which is linked on the slides. And these have come from there. And these are kind of highlighting that age and vibrancy can be tied together, as the women who I co-create a lot of research with also tell me, and also the research shows long-standing ideas that actually women don't associate themselves with the term older. And we tend to use the term aging to take away that kind of sting of the label and to kind of honour that perception. So the research, unfortunately, in terms of the media reflections of the discourses of growing older in Twitter and X, for example, show that actually the messaging and the images and the discourse is actually quite an ageist. That is, that it locates older adults in a disempowered, vulnerable, kind of deteriorating and those kind of negative discourses and homogenous group. There's no kind of like variation in terms of how they're framed as a problem, and that aging is something that should be resisted rather than embraced. Next slide, please. So in fact, as I've kind of illuminated, aging is not just about the number. There are multi-dimensional processes that change over time, and this definition here of the next two slides really nicely outlines that for me. So you've got biological process, obviously your physical age, any physical disabilities, for instance, and your psychological and social age, which I'm really interested in as a researcher. So the next slide highlights the psychological and social in terms of this perforated line in the middle where you can see the box that says social and self-perceptions. So as the introducer mentioned, we kind of internalize a lot of the reflections of these discourses that I mentioned within ourselves, in our self-beliefs, but also in the stereotypes and kind of perceptions, meta-perceptions that we hold as well, what we think other people think of us. And this forms what we call our subjective age. So how old we feel, as well as these other factors that are outlined in this nice diagram in terms of, for instance, milestones in our life, like maybe having grandchildren, that's our lifespan age, organizational age, maybe retiring, somebody mentioned that, which is quite interesting, and that's really quite an important cut-off point as well. So these all have an impact on how we perceive ourselves and our subjective age, which is really important, as I'll illuminate in the slides before I hand over to Sharon, because actually this has all been shown to improve or be a barrier for our well-being. If we have a better view of ourselves growing older, we tend to have better health and well-being. Next slide, please. And so as we balance all of those factors in respect of growing older and that shift in our future time perspective, basically having less time left makes us reassess and kind of shift our motivation, and we adapt accordingly in terms of what this theory that's outlined on the screen is called socio-emotional selectivity theory. So that is, we prioritize our life reconciliation, our kind of evaluative well-being over that hedonic ups and downs, that kind of thrill-seeking, having lots of friends. We tend to prune our relationships and focus on the meaningful relationships. And this motivational shift actually has some significant impacts, which I'll show you on the next slide, please. In respect of media, so in how we frame media is really important in respect of this theory, because we tend, as older adults, as we're growing older, the research shows by Laura Cartensen and colleagues that we have a preference for positive stimuli. That is, we don't attend to the negative stimuli, for example, the news, or thrill-seeking stimuli that's about kind of, you know, that hedonic kind of emotional content. We tend to focus on more positive stimuli that reaffirms our kind of life reconciliation and our achievements. So this is an emotionally protective strategy. It's not cognitive decline, and it has impacts for well-being as well in a positive way. So next slide, please. So research shows actually, if we frame media, social media or other media, in terms of the positive, i.e. focusing on uplifting stories over adventure and that thrill seeking, and the kind of more kind of like stimuli, emotional stimuli driven, instead we're looking at, rather than high arousal stimuli, emotionally meaningful. So as I say, that life reconciliation and life evaluation well-being kind of framed messages. So we tend to hold attention more to those kind of positive messages, essentially, and those fear-based appeals are less appealing. Next slide. And why this is really important is actually a really positive story, because all of these negative discourses that I've highlighted around deterioration, that people obviously have already engaged with in terms of that burden here in the audience, but those other things that are reflected in the media that the research shows in respect of aging being something to be resisted is actually not based on reality, because we are happier as we grow older, and that's kind of something to be celebrated. So media should be designed with this in mind, by promoting positive emotional experiences and aging identity affirmation and meaningful engagement. Next slide, please. So just give you a very quick example from my own co-created research. So this draws upon a study with older women aged 60 and above, I should say aging women, sorry. And one of the themes that came out, it was a focus on lower paid workers and part-time workers, was around this idea of a perception of being seen as not being good at technology. So a quote being, it's like the dinosaurs, if you don't move on, you're extinct. And another colleague, another participant talks about her colleagues kind of looking at others for training opportunities, but not her, because she was older and she was perceived not to be kind of like, you know, needed in terms of that development in terms of technology, but she felt that that was quite patronizing. And so there was a disconnect there in respect of what older people felt they could do with a bit of patience and a little bit of time and a little bit of support, and actually what they felt colleagues and supervisors felt of them, which was more negative than they felt was warranted. Next slide, please. And this is really interesting when you look at the research, because this really, it highlights why this is such a stereotype. Because if you look at how this is an example from age 55 plus in China, there's 4 distinct clusters. And if you can see here that the high technophobia cluster is the lowest, so there's only 20.55% in that cluster by this research by Sun and He and colleagues. So this is really interesting. The actual highest group was the high privacy concerns group, and low technophobia was higher than high technophobia. So there's no homogenous group here, and that this is really important, because this kind of shows that this is a stereotype that definitely is unfounded. And if we go further into the research, and the next slide, please. Actually, we can see this subjective age, so how we feel, is really important, and how technology has an impact on people is kind of actually there's mixed research, but there's positive impacts of technology on well-being. And if you feel younger, has a protective effect. So if you feel that you're able to, you're not kind of like as kind of deteriorating. You see aging as a positive thing, with tying it with vibrancy, for instance, that can have a positive impact on our actual function in terms of our competence with technology. And so this is really important because it suggests that interventions that foster aging identity or challenge the old equals technophobic trope may directly reduce tech anxiety. Next slide, please. So the research that I just alluded to shows that actually ICT does not harm older employees' mental well-being, and it does not impair their job performance. And actually, many older workers adapt effectively when that support and training is provided. And actually, some research shows that digital technologies have been shown to improve the quality of working life for older workers. And this is really important. This is something that's under research, granted, but the researchers of this study highlight that actually this needs further exploration. For example, the intersection of aging and gender, because we know that there are more kind of challenges in respect to the combination of ageism and lookism as we grow older as a woman in many ways. So the next slide. I think I'm handing over to Sharon now. Thank you very much indeed for listening, and I'm delighted to hand over to Sharon.
Thank you, Claire. Thank you for this very interesting opening address. And I will build on what Claire talked about, asking the question, how can we fruitfully leverage media to guarantee a positive experience to everyone? And what role does context play in making sure that our interventions are designed in an effective way to really support the people who will ultimately make use of the media and technology that we are planning to deploy? And to do that, I will look at issues surrounding access to technology and media, looking at the way in which culture frames and our culture understands media, uses and gratification, and bring everything together into considering the potential influence that these factors play in the outcomes of interaction with media. Next slide, please. Okay, next slide, please. Access. We start with access to media. And we know, based on recent statistics, that the vast majority of the global population has access to, for example, the internet or a mobile phone, even to social media. Out of 8.20 billion people in the world, we have 578 billion with a mobile phone, 556 have access to the internet, and 524 have access to social media. However, the next slide will show that there are significant blind spots. If we look in terms of absolute numbers, we see that India and China top the classification of population that is still unconnected to the internet. And we see a staggering 651,619,000 people in India who do not have access to the internet. And this seems a very big number, and it is. However, if we consider that India is the country with the highest population in the world, and that number constitutes only 44.7% of the population, we see that, yes, there is a lot of work to be done. But the situation overall is not as bad as what we see in the right-hand side column. That is the percentage of people who do not have access to the internet in each state. So what this slide tells us is that connection to the internet and access is certainly an issue to be considered, but we need to be able to contextualize it and have a more granular approach to be able to identify problematic issues and plan interventions appropriately. Next slide, please. And when we're planning when we're planning the interventions, it's important to consider that, yes, at national level statistics are interesting. However, within nations, we can see gaps emerging in access to internet, for example, emerging from different factors. For example, when it comes to geographic positioning, we have rural population having significantly less access to internet compared to their urban co-citizens. Age-based gap is also significant, with people in an older population having less access. Gender, and Claire was mentioning it before, women have less access, and poorer people also struggle more with access. What is important when we consider all these statistics, including a graph that I included there on language, because it's also important, we need to speak English to be able to access the vast majority of the content available on the internet. All these issues combined, they're not isolated, and an intersectional lens really helps being able to design effective interventions to support people who are feeling cut out of the current dialogue. Next slide, please. Next slide. Okay, so it's true that there are, next slide, there are cultural differences, but it's also true that there are significant differences in the extent to which people use media for different purposes. So uses and gratification is one of the biggest theories and contributions psychology has given to media literature. And basically it says that the effect of media depends quite heavily on the reason why we are approaching media. So we get out of media what different things depending on the reason why we use it to begin with. And if we look at the recent statistics, if we look at recent statistics, we can see how there are significant differences in the reasons behind internet use across different age groups. So the younger population on the left-hand side of this graph tends to use media more often to interact with their friends. And if we kind of cluster a bit more the reasons, we can see that entertainment seems to be one of the main uses that young people have for media. The more we move towards the right-hand side of the graph, we start noticing a shift where we older people tend to turn to the internet as we would to an encyclopedia or a source of information. We privilege the uses of the internet to access up-to-date current affairs, information, learning material, etc. When we design interventions for digital inclusion or for supporting well-being, it is important to manage the expectations and to be aware of what people are looking for and why are they approaching particular tools. Next slide, please. Okay, so this is important in general, but there is another layer that is important to consider, that is the cultural lens. our cultures, in the next slide, influence significantly the way in which we use media. And it drives not only what we're looking for when we interact with media, but also how we interpret and monitor and regulate our own behavior. So, for example, there is a study that looks at American and Korean students and how they use the internet. And it shows that in both cultures, of course, people need to start from a sense of self-efficacy, and internet is used to improve self-efficacy. But in the US alone, the behaviors are very different. So in the US, people use it to network more, they use it to negotiate and establish higher status. They use it to express themselves more than it happened in Korea and South Korea. And similarly, the US participants were the ones who, when they felt they were using it too much and they were getting a bit overdoing it when using the internet, they were self-regulating and they say, no more. They stopped and regulate their behavior. On the other hand,
You, Sharon, you have just 4 minutes. You have just 4 to 5 minutes left.
Oh, 4 minutes left. Okay, perfect. Thank you. So this is another factor. Next slide, please. I'm almost done anyway. So it's important to consider, so the individual expectations, the use is driven by culture, but also the cultural frames and the understanding and expectations that come with aging or are assigned to an aging population by the cultural context one is in. And we've already seen with Claire how in her exercise, the participants here had narratives around respect, interdependence, and narratives about decline and burden. So these kind of narratives become very important. Next slide, please. Next slide, please. All these factors really influence the outcomes of our interventions. We need to be very careful to consider the idiosyncratic challenges that are faced by individuals, older people in different cultural contexts. So, for example, in this study, there were 3 different countries, and in a series of case studies, this paper identified culture-specific challenges that were addressed effectively by interventions and therefore guaranteed positive outcomes in terms of well-being and digital inclusion. In particular, in Germany, there was a stigma around asking for help. So older people didn't want to ask for help. And what they did at that point was to offer easily accessible community centers so that the elderly didn't have to ask. They could just turn up and get the help they needed. In Japan, there was an issue surrounding the preference for face-to-face interaction. People preferred to interact face-to-face. So the intervention in that case had a mentoring scheme where people could get together and work together to learn about technology and technology use. In Thailand, there was a big challenge linked to access to internet and infrastructure in the rural areas. So what they did at that point was to make sure there were government regulated and issued centers where people could have access to mobile phones, smartphones, and could learn to use it. Next slide, please. It's important to see how these different factors map onto the outcomes of using media and technology. And for example, in this study looking at the way in which people interacted with social media, we can see that you can have a plethora of positive and negative outcomes. But the next slide will show you how these really depend on the cultural context. So, for example, you remember Japan had a problem with face-to-face interaction. And indeed, when you have a problem with face-to-face interaction, no, it's not a problem with face-to-face. You prefer face-to-face interaction. So if you prefer face-to-face interaction, obviously you don't see a value in social media, and social media will have less positive effects due to the cultural rule. On the other hand, when you have rules concerning the rural community norms and isolation, you see that people who are prevented from accessing social media because they don't have access to the internet due to their geographical location, they will have negative outcomes and they will feel even more isolated, like in Thailand in the previous study. And finally, when there are issues surrounding interdependence, like in Germany, where people did not want to ask for help, here we see how internet, social media use can foster feelings of autonomy or be the reason why people resist using social media. So in the next slide, we bring it together to say that we need, whenever we design an intervention, to have it adapted culturally and to consider intersectionally, like Claire was saying earlier, all the factors and how they shape the experience when we are when we are devising an intervention. And research suggests when we do that, when we are mindful, then technology and media can really be helpful. So media can be a problem, but also a solution. I can leave it here.
Yeah, that's great. Thank you, Sharon. Thank you so much. I was really such a enriching presentation that you were giving. So I had to stop you here, but you were on time. That's great. That's great.
Okay, thank you.
Next speaker is Professor Ashiman Nehra. She is not just a teacher to me, she's a mentor. So over to you, ma'am. Ma'am, kindly unmute.
Give me a minute, please.
Okay.
Hi, is my screen visible?
Yes, it is.
If you can full screen it.
Yes. Is this okay? Am I audible?
Yes, ma'am, you're audible.
Perfect. Good evening to all of you here. Thank you so much, Dr. Swati, and all of you, and especially Helpage with Swati support. It is absolutely my pleasure to be here today and interact with all of you and learn from all of you. The topic today that I am planning to cover is brain health and dementia in India, a preventive, promotive, and a rehabilitative approach. Yeah. So,
Ma'am, if you can go in the
yeah,
press.
is this okay? Yeah. Sorry about this. Yeah. So overall, there is a global aging burden of dementia, and aging population, especially in India, is increasing, as spoken by the two former speakers. Understanding brain health and dementia is absolutely an urgent need. Preventive strategies, promotive strategies, and what are the rehabilitative strategies which can be used for care, the key challenges in India, and also the way forward is what we plan to cover in this talk today. Uh, Global aging is definitely a fact, and population aging is accelerating globally. By 2050, nearly 2 billion people will be aged 60 years or older. This major demographic shift poses significant challenges for countries to ensure their health and social systems are absolutely prepared to respond effectively. Population aging will drive a sharp global rise in dementia, with cases projected to reach 131.5 million by 2050, an alarming trend. Why it matters in India? Because as we stated, the population of dementia is increasing, the age is increasing, and there is rapid demographic change. The non-communicable diseases are uh, are a major risk of death and disability, and especially which are neurological in nature, which includes stroke, head injury, and stuff. And India reflects a global challenge which needs to be scaled. Hence, it is important to understand the brain health and dementia, and brain health as a new target of the world as well as especially India. So, there is a need to shift from disease focused thought or care to a life course brain health approach. Cognitive decline progresses from normal aging through a silent preclinical phase to mild cognitive impairment and eventually leading to dementia, where impairment increasingly interferes with the daily functioning, hence becomes a burden. Potentially modifiable risk factors for dementia, according to a 2020 Lancet Commission report, is predicted. So there are two types of prevention strategies that have been found, which is the pharmacological and the non-pharmacological. Broadly, pharmacology can include ongoing trials, preclinical population, and also the non-pharmacological, stronger current evidence-based practice to a scientific and objective models. Promoting brain health and beyond prevention. So there is a shift from disease, as I stated earlier, disease prevention to brain health promotion across lifespan. And multi-domain brain health approach combining lifestyle and personalized intervention can effectively preserve cognition and delay decline across the risk groups. So building brain resilience and cognitive reserve is very important. Brain health would mean an ability to adapt, to function, to stay resilient despite aging challenges. And brain health can be sustained across the lifespan through a modifiable lifestyle, social and digital interventions that enhance resilience even in the later life. And a multi-domain would be non-pharmacological, as I stated earlier, approach, which will enable people with dementia to live well by preserving function and independence and quality of life, as was stated by Dr. Swati at the beginning of today's webinar. The key intervention and mechanisms should include cognitive interventions, very well known, the physical and the life interventions, the psychosocial factors. Besides that, it is important to integrate all the cognitive, physical, psychosocial interventions and enhance neuroplasticity and resilience and improve functioning and well-being in dementia. It will help enable effective rehabilitation. So the rehabilitation has to be person centric, technology enabled, and community based care, supported by caregiver training, drives scalable dementia care, and improves daily functioning and quality of life. And we will state that we've already attempted to cover some of this. Dementia occurs in stages and different forms. And the care also has to be at the different stages. And it has to be each stage specific. And it has to be different based on the needs of the patient and the caregivers. For example, at a late stage, sometime probably, a support, a love, a care, a comfort, a reassurance, etc. So at every stage, it will be a different kind of intervention needed. World Health Organization brain health work clearly states that we need to strengthen policies, service delivery, health information system, and provide technical assistance on how to formulate and integrate approaches to brain health conditions, which should be focused on promotion, prevention, treatment, and rehabilitation, and focus on low and middle income countries first, because we have a large population and the dementia. Of course, where the dementia can be seen, of course, at a community or a level, or it could be when the patient is brought to a hospital setup or a clinic or basically a rehabilitation center. So the first point of contact there would be a medical doctor who will do a history taking, who will formulate the provisional diagnosis, and may refer the patient based on a specific question in mind after having screened the patient to different sources, for example, biochemistry, microbiology, or X-ray. We also refer the patient for psychodiagnostics, or on based on his view, what he thinks. So ideally, what is happening is the focus is on reducing the burden, and so hence does it together, everybody put together, the medical professional or the sources of referral and management through the allied and healthcare professionals. So it is a multidisciplinary team effort approach, as is recently even stated in again another webinar on a post-budget session with the ministry. So the focus is on policy and program and landscape. So which is government's pushes towards Indian government's pushes towards building skilled workforce capacity with the support of NITI Aayog. So the key need is national dementia strategy and stronger implementation. And so there is a focus on workforce development through National Commission for Allied and Healthcare Professionals Act, which had come up in 2021, which is a major structural reform with long-term impact on brain health services. And through this, they are trying to regulate 57 professions in this country. And they're trying to create a very big workforce which will be ready to work even at the community level. In one of the recent studies, where 51% of the patients had consulted a doctor, yet only 5% received a dementia specific diagnosis or treatment, indicating a major treatment gap of more than 90%, even in a relatively well resourced Indian state. So, low awareness of dementia remains the key barrier, hence, we are working in this direction. So, there is absence of comprehensive national dementia strategies in much of Asia contributes to the gaps in the early diagnosis and contribute coordinated care and long-term planning. Very few memory clinics exist in our country. However, no published working model is yet available. Only one single guideline for memory clinic is published by Alzheimer's and Related Disorders Society of India, ARDSI. Well, now what is the way forward and how is it globally relevant? Indigenous assessment tools, workforce capacity building, primary care integration, and caregiver support system, scalable digital solutions are a way forward. And India has offered a community-based model. So the task shifting innovations are underway. Low cost, scalable approaches are right now, being focused on. And India, as a learning model for the low middle income countries and beyond. And besides that, the focus is on integrate brain health into primary care, to focus on scalable community-based models, leverage digital health solutions, and culturally relevant interventions. With government's pushes towards having, uh, basically a health tourism available in this country, and trying to kind of leverage and work on all the loopholes and connecting all the dots. So, with the focus on integrating culturally tailored brain health into primary care, leveraging community workers, digital tools, enabling scalable, early, and equitable dementia care, especially in underserved settings. And with this focus on culturally relevant intervention, indigenized models. And they are focusing because we have diverse languages, a diverse type of population. So they would like to have their own indigenized work that we need to focus on. With the workforce capacity, as I stated earlier, 57 professions are being regulated in this country through this act. And then policy and system strengthening through implementation, and also research and innovations are underway. So culturally adapted, family-centered support system supported by workforce training, policy alignment, and local research, which can be enable scalable and sustainable dementia care in low middle income countries, and prepare this model is at the moment the focus. At AIMS New Delhi, a substantial work has been undertaken in dementia care. A study on dementia awareness showed highest awareness among healthcare professionals, which is about 46% of people, followed by caregivers, which is about 26%, and older adults, about 25, 26, and in which Dr. Swati Vajpayee has definitely done a tremendous amount of work. There are other national centers of aging in the country who have been working very hard besides AIMS New Delhi. It's the King Institute of Prevention Medicine and Research, Chennai, is also working in this direction. Besides that, at the Genetic Medicine Department at AIMS, as well as the Department of Psychiatry at the NIMHANS, the National Institute of Mental Health and Neurosciences Center, Bengaluru, has also worked tremendously in this direction. As was stated earlier in the presentation, I would like to state here this is an excellent work that has been done by Dr. Swati Vajpayee as a part of her PhD program, which she took up and developed this intervention model purely for dementia. And this model is based on randomized controlled clinical trial model, and which is a home-based approach, the very approach that we are voicing, where it is the caregiver who is the therapist while the person is at home. So a model has been developed, the caregiver is taught, and of course, caregiver burden is also taken care of, and eventually the patient will go back and he will undergo this kind of a therapy, will come back to a clinical setting once in a week for a period of 8 weeks, and following an AB experimental design format. And this is the model that has already been done and now way forward. I would also like to place on record here that the ministry has recently in India, the health ministry has doled out a major 100 crore rupees only to develop, allied and healthcare professionals in this country, which is the first of its kind where the government support has been given. And our Indian government, especially Ministry of Health and Families Welfare, is giving tremendous amount of support to move in this direction with a vision to be future ready for this elderly population. So we are committed to comprehensively approach spanning prevention, modify risk factors, vascular health, early screening, promotion, and cognitive reserve, community engagement, and digital inclusion and rehabilitation, which is introduction, planning, development of non-pharmacological care, and focus on caregivers and community based approach, which is the primary goal of the National Commission of Allied and Healthcare Professionals. And we acknowledge key strategic challenges, awareness, assess workforce and affordability, and look forward to contributing to a scalable culturally relevant, and integrated brain health solutions across India. Uh, Last of all, I would like to state we treat a disease, you win, you lose. You treat a person, I guarantee you win, no matter what the outcome, as stated by Patch Adams. And I would once again like to thank you for giving me this opportunity to interact with you. Thank you.
Thank you so much, ma'am, for such a wonderful and a comprehensive presentation. I mean, and thank you for the appreciating words as well. So let's move on to our last but not the least speaker. That's our Dr. Kirti Ranchor.
Yeah, Swati, if I can just make a small announcement. Participants, if you could just put in your questions and comments in the Q&A section. Because I don't see any questions as of now, and I don't believe that there can be no questions. So just requesting the participants to please put in their questions or comments in the Q&A section. Thank you.
Thank you, ma'am, for making this important announcement. Kirti, over to you.
Hi, thanks for the invitation. So should I share or are you going to share?
Kaling, could you please put Dr. Kirti's presentation on screen? Perfect. Over to you.
Thanks, Swati. I'm going to be looking at brain skills training. So I think similar to what Swati does, just slightly differently for healthy aging and brain health. And I'm going to start, next slide, please. I'm going to start with a little introduction to me and why I'm doing the work that I'm doing and why I'm doing it in the way that I'm doing it, actually. Because I think the framing is important, particularly given that I've branched slightly, I'm doing work slightly differently from my core training, which is as a neurologist. So I'm trained as a neurologist and finished many years ago and loved the field, but had a very busy clinical practice and recognized that potentially, we were intervening at a point that may have been a little bit too late to prevent or promote health. In addition, I think there's a lot of people who are living with specific illnesses, and there was a recognition that in a busy clinical practice, it was exceptionally hard to give the advice in a very practical way to help them. And so that's how I started on this journey. At the same time as I'm contemplating that, this is my grandmother and my grandfather. My grandmother had Alzheimer's disease. That's my mom, aged 1. So my grandmother had Alzheimer's disease. I was already a neurologist, and I think it was an eye-opening experience from the limited knowledge that was publicly accessible, the limited knowledge that was accessible to me as a neurologist as well, and the understanding that at the core of helping somebody with dementia is actually care, not neuroscience. And I think my aunt and my mum were really so helpful in helping my granny. So that actually started the journey. I am based in Johannesburg. The bottom right hand corner is Johannesburg with a very beautiful sunset. But there are other experiences, including neuroscience and this personal experience that shaped what I do. So, including art and music, which I will introduce. That is my father painting. So, I've been painting since I'm 8 years old with my dad on a Friday night. He's also a medical doctor. Currently, he's retired and he paints. Next question. Next slide, sorry. An outline, we'll just start with definitions of brain health and healthy aging for the presentation, and then go through resources, how we can start thinking about resources for health differently. And I'm going to center the discussion on brain training, on neuroplasticity, looking at lifestyle habits, but then particularly what do we have rooted in our cultures and our traditions. As I said, I'm based in South Africa. So the examples are principally South African or African examples, but I think they're a useful example that can be adapted to different contexts. Next slide. So when we look at brain health, and I thought what was interesting is that the definitions of brain health and of healthy aging are very aligned. So brain health as a state of brain functioning across different domains, cognitive, sensory, social, behavioral, that allow a person to realize their full potential over the life course, irrespective of the presence or absence of disorders. And healthy aging is the process of developing and maintaining the functional ability that enables well-being in older age. And I think there is this emphasis on function, on our ability to engage with the world in the way that we choose to. From the health model, what is understood, we look first at health promotion, then we look at risk reduction, so that would go into prevention, diagnosis, treatment, and care. How do we respond? How do we ensure that there are adequate services available, treatment available? But there is a huge amount of work that can be done in the health promotion and health prevention space as well. What are the resources we need to support effective health is one of the questions that I contemplate in this. But I think also we have to start looking at what our priorities are, and I won't dwell on that, but just to start thinking about it, both from an individual level and a systems level. Part of how we respond has to be to understand our priorities and the context within which we operate in. Next slide. So I like this as a metaphor for healthcare. These are a set of ostrich eggshells from a museum in Johannesburg, the Origin Center at the University of Witwatersrand. And I do a lot of work in this museum. But these ostrich eggshells I use as a metaphor. They are beautifully decorated ostrich eggs that were used to store water by the Khoi and San people in very arid areas. And what was understood was that this was an exceptionally hardy substance. You can stand on it, you can throw it, it doesn't actually break. It is impermeable and therefore a good resource for storing water. And it was available in an area where water was scarce. So ostriches are also in these areas that are arid or semi-arid. And so the Khoisan understood that this was a good resource to store water, and this was critical for what they needed. Can everyone hear me properly? Because I see I've got a unstable internet connection signal on my...
Yes, doctor, we can hear you perfectly.
Okay, perfect. And so Khoisan understood what they needed to do, store water, and they understood the resources that were available because there were ostriches with ostrich eggs in the same environment. And I use it as a metaphor for health because we have to understand the problem that we need to solve in the area that we are in and the resources that we have available to solve for this problem as well. And to be provocative, it would never work for me to ask people in London to store water in ostrich eggshells. Firstly, they have a huge river, so there's an abundance of water, and they don't have ostriches. And I do sometimes wonder, and again being provocative, but I am, I do sometimes wonder if that's sometimes something that we do in health, even if we are adopting it, looking at the problem from the perspective that's not rooted where we are at. Next slide. So I'm going to focus on neuroplasticity, but really make it practical for what we have to do to support brain health and healthy aging. Neuroplasticity is also known as plasticity. So the two terms are used interchangeably within the neuroscience field. And its origin is from a Latin term that means to mold or to form. And that is useful because it really represents a structural or functional change in the brain in response to something in the environment, either external or internal. So when we learn new information, when we become skilled or develop a skill, or sometimes in response to damage to the brain, how the brain adapts, that is the response to the internal or external environment. And what happens in the brain is you have new connections forming between different cells or new cells generating. And so that's the process of neuroplasticity. Next slide. I think this is one of the best known examples, and I like using it because I really do think it illustrates this so well. So, a study done on London taxi drivers showed that the parts of the brain that developed were responsible for spatial navigation, navigating through a city, and this was in the hippocampus in the brain. And what it showed, this was before Google Maps. I think it would be a completely different study currently, a completely different outcome currently. But in essence, the brain is going to develop the parts that we need to function efficiently. That's the basics of this information. Next slide. And so we come to the earliest, some of the earliest descriptions of plasticity. This is Ramon Kayal, I'm mispronouncing it, but he wins the Nobel Prize in physiology or medicine for his work on this. And I bring it up to show how old this research actually is. 1906, and we are in 2026 and trying to emphasize the importance of this. So what happens is that he does win the Nobel, but this evidence or this research actually takes a back foot in scientific academia. And there's a resurgence in the 60s and 70s. And it is interesting to understand how, yeah, how knowledge can be distorted or ignored over time, but then also how it can be, in a sense, the word is wrong, rediscovered for us to make use of it in the time that we are in currently. Next slide. And to link it to neuroplasticity and what we can do to support brain health or healthy aging, I love this quote from Mahatma Gandhi that our greatness lies not so much in being able to remake the world, that is the myth of the atomic age, but in being able to remake ourselves. Because I think this links directly to the concept of neuroplasticity, our ability to make specific changes to ensure that we can support better brain health or to ensure that we can age in a healthy way. Next slide. I think many people in the room will be familiar with the research that is available that shows how lifestyle factors have a huge impact on brain health and healthy aging. And from a clinical perspective, I can tell you that it's exceptionally difficult to give people all this advice, right? There's a list of over 10 things that people need to do to stay healthy. People have no time, they're exceptionally busy, or they have resources that are not accommodated within this framework. And so the challenge becomes understanding what has to be done, looking at the research, but also making it exceptionally practical for people so that they are able to implement it. Next slide. Thomas Sankara was the president of Burkina Faso from 1983 to 1987. And I bring him up here because I think sometimes, or at least for me, looking at brain health, healthy aging, mental wellness, the complexity of what has to be done, the challenges involved in doing this, both from an individual perspective or, like I said, organizational systems perspective, I think it's important for us to look for examples where people have understood what needs to be done, looked at the resources available, and actually managed to get it done. So, remarkable president, 1983 to 1987. His term ends because he's assassinated in 1987. In less than 4 years, he vaccinates over 2 million citizens without much external funding. Burkina Faso goes from a country that is food insecure to having food surplus during his tenure as president. Literacy rates increases. He starts a green movement and ensures women empowerment. And yeah, if there's a person that I would love to meet and a brain that I would like to understand, it is his. Because when I look at it, the complexity, the how we would define resources, he looks and he says, what resources do I have? And he understands that he has the resources in his environment, namely people, relationships, community. And this is what he taps into to restructure how he runs this country. Next slide. So these are the examples that I wanted to share in this group, looking at resources rooted in community or rooted in different cultural systems. And one of the most excellent is the Friendship Bench. Dixon Chibanda was a psychiatrist in Zimbabwe. At the time, there were 5 psychiatrists serving 10 million people. He obviously is despondent and frustrated at the time because he's seeing that he's limited in what he can do and how he can care for people. And we understand how long it takes to train somebody to become a psychiatrist. So while we can say there is a need for more psychiatrists and psychologists, we also have to understand what we can do practically. And so I think you said it initially, I thought, how could I possibly do this work with these grandmothers? They're not educated, I was thinking, in a very Western biomedical kind of sense. You need psychologists and psychiatrists. But what he starts is that in 2007, he starts with 14 grandmothers. And he gives them some training, but he understood that grandmothers are respected in the community, that they have a skill set and resources to actually help people in the community, that this is what they are doing in essence already. And he just facilitates the process, supplements training, and then starts to the point currently where over 820,000 people have been seen. There's been a 78% reduction in depression and suicidal ideation. And he has lots of published research in all the big medical journals as well. But it shows how we need to look at a resource within a community and develop this with the community differently. I think so much of our narrative focuses on what we don't have versus what we do have. And yes, I think this is such a powerful example of understanding resources, understanding the problem, understanding how to develop these resources and work going forward. Next slide. A lot of my work would also incorporate art. I'm going to share a story that I was introduced to at an exhibition at the Wits Art Museum, also in Johannesburg. And this was the Stars of the North exhibition, focusing on artists from the northern part of South Africa, Limpopo, predominantly sculptors, sorry. And this is the art of Putuma Sioka. So Putuma Sioka was a sculptor from Limpopo, and he was having these recurrent nightmares. Because he was having recurrent nightmares, he went to see a Sangoma, which is a traditional healer in his village. And the traditional healer recommended that he sculpt. And this is actually such profound advice on many different levels. And I emphasize that not advice that we would have, things are changing currently, but not advice that we would have given clinically with neurology or medical training. And that this was known within these traditional societies across the globe, not only in South Africa, on the value of art to support him. So, what did the traditional healer do? He made an intangible problem, whatever was causing his nightmares, tangible. So, he was able to problem solve in a different way. And when you look at the neuroscience of art and health, it is also very fascinating because it, in essence, activates a network in the brain called the default mode network. This network allows us to understand ourselves, potentially to understand others. It helps us to process autobiographical memory and to project ourselves into the future. It, creating art has also been shown to improve psychological resilience in some studies. So the traditional healer understood the impact of creating art for this artist, Putuma Sioka. And the neuroscience here is only showing the neuroscientific elements. The traditional healer understood that it worked. Next slide. So when we look at art within a community, these are African art sources, which I'm going to emphasize, but I'm using it as an example because I think we all have it in our traditions and our communities, even in our family structures. And art forms can be sacred or they can be secular. And whether they're sacred, whether they're secular, whether they're good or not, actually, the process of creating art does have benefits for health. And whether this is beadwork, whether it's what gets classified as craft, we have to understand, can it help people living with an illness or can it actually promote health? Next slide. Forms that are embedded in our cultural systems. These are artists that I've done work with. Pops Mohammed, unfortunately passed away last year, wealth of knowledge and an amazing talent, focusing on ensuring that indigenous music instruments were played and understood and not just housed in museums. He is pictured on the left-hand side of your screen playing the kora. The second is a mbira, which is a thumb piano, also indigenous to the area. Third image is a friend and somebody I've done work with as well, who's playing the uhati, a indigenous instrument made with a calabash. She understands how to grow the calabash, how to treat the calabash to actually create this instrument. And the last is musician playing the sarod, Rabin Ram. And I bring it in here just to show the wealth of resources that we have to stimulate the brain, to live well, to create community, and to enjoy ourselves. Next slide. The last example comes from President Nelson Rolihlahla Mandela. And it is a quote that he relates from his childhood. And what he says is that after supper, we'd listen enthralled to my mother and sometimes my aunt telling us stories, legends, myths, and fables, which have come down from countless generations, and all of which tended to stimulate the imagination and contain some valuable moral lesson. As I look back to those days, I'm inclined to believe that the type of life I led at my home, my experiences in the field where we worked and played together in groups, introduced me at an early age to the ideas of collective effort. And again, I think it is to emphasize that this resource that we have within our traditions, within our communities, within our cultural value systems are so important for us as we look at brain health and healthy aging. Next slide. I think it's the last slide. Next slide. Oh, sorry, two more slides. This is just to summarize for neuroplasticity. I'm not going to go into this slide now. Next slide. So when we look at the brain and brain health or healthy aging, we have to understand. So that would be the health literacy aspect. We can train the brain in different ways, either systematic programs, but also to understand the cultural resources that can be adapted to do what we need to do to optimize brain health and healthy aging, and really so that we can enjoy life and live well. Next slide. In conclusion, we have an incredible brain that can learn from our experiences and that we use to adapt to our environments. The most remarkable aspect of this is that it's a dynamic process that continues throughout our lives. Given that, the question is, can we consciously choose our experiences to shape our lives, our world, and our health? Thank you.
Thank you so much, Kirti. It's
Thank you, Sati.
just an amazing presentation.
Thank you.
So, in fact, I would say all the speakers were amazing. You know, the kind of information that they brought on this platform was immense from the different perspectives. I myself have a lot of questions, but before that, I'm going to ask there are a few questions on chat that let's take it one by one. Uh, Hello, is there any questionnaire which we can fill and understand about our brain health? This is so pertinent to our GBHI questionnaire. Like, is anybody who want to answer from the panelists that is there any kind of a work which is going on or any kind of a questionnaire a person can understand about their brain health?
There are some resources that are available, but I think that it is quite complex as well. But there are some resources that are available. I'll add it to the chat. But I think also a lot of it has been designed in specific contexts. And so some of what is asked ends up being biased if you come from different cultural systems. So a lot are developed in the global north. And because of it, the way people socialize, the way they engage with art, the way they learn is very different from, where I come from. I assume a lot of people here come from. And so they end up being a bias, but they're still helpful. So I'll add one of them in the chat box. But yeah, and that is I think it takes 1.5 hours to do. So just to understand the complexity of actually doing an assessment for brain health it's not, yeah, it's not like the heart, right? Like I think anybody who works with the brain realizes it's not like the heart. I'm going to measure an enzyme and problem solve, I'm going to look at an EEG, done. So I think that's a challenge.
Yeah, true, very true. So the next question is about a person who is asking as a commoner that I'm a sociologist and a social gerontologist. How can one identify when it is the right time to seek medical help? Many people in their mid 40s and early 50s experience forgetfulness, difficulty recalling names, or trouble remembering specific terms. They often assume these are simple signs of aging. Professor Ashima, ma'am, would you like to answer this? What
Yes,
are the early signs?
yes, definitely. I'd like to say that the moment you start to feel that you're failing in memory in some issues or something, it is best to come and get yourself screened. So for that, there are many centers within India, and especially, for example, AIMS also. One can come, one can get a card made. I mean, this is the process. This is exactly what I had pointed out in my presentation, the continuum of care model, where there would be somebody who would immediately see you, will send you to the right source, and first of all, they'll screen. And based on the screening, if the cutoff shows that you are having an issue, they may refer you for psychodiagnostics. And based on that, which is based on objective and scientific measures, we would be able to tell you if actually it is mild cognitive impairment or if it is moving towards having memory issue. And if not, we can tell you that as well. So the moment you feel is the right time to come forward.
Very rightly said. I mean, it's whenever you feel that there is a need to be assessed, I think that's the right time to get an assessed. Probably not assessed, probably get screened even as early as possible. Next question is, how does technology, apps, AI tools help in monitoring or improving cognitive health in daily life? Anybody who would like to? Actually, I'm also working on the technology app, so I can only answer that yes. I think technology has a lot of digital things going a boom over here, and using a lot of apps, memory health apps and memory improvement apps. So yes, technology do help you to understand that how you are able to measure your cognitive domains or cognitive structure. So yes, technology is actually a boom for us. And I believe that with elderly, there always a challenge, because having, getting them attuned to the technology, there's always a challenge. So we try to make those apps and those cognitive tools very culturally relevant so that they can use it. So yes, technology is a kind of a good thing. Anything you want to add, Sharon or Kirti or Claire, to this question?
Okay, there are
Okay.
tools that have been developed and apps to assess different cognitive abilities, and they've been aligned. But like Dr. Rancho was saying before, a lot of it is culturally specific, and I would love to see a bit more diversity and more respect ways of understanding brain health incorporated in technology. But for me, at least, the best way to do that is to have a bit more culturally humble approach to app development and technology development, and understand that actually there is so much more knowledge we assume, and we need to build technology with our target populations, not for our target population. I think that's the key.
So true. So
I
true.
like one thing. This is a little beyond uh, assessment. I would talk about rehab, as is very well known in our psychology circle that the best support system is pet therapy. Very interestingly, I saw Japan is working on AI dogs. Yeah. So you don't have a responsibility of giving food. You don't probably have energy to give food or even walk them. So the dog would behave the same way as a normal dog. And amazing. I mean, this kind of a technology has already come up. I don't know how the effect would be in India. This is interesting.
Okay, so the next question is, are there any potential screening tools recommended for early diagnosis, which is widely used in community settings? And importantly, how counseling session helps a person living with dementia?
May I say something here?
Yes, please.
First of all, it is very important for everybody, including the patients, the clinicians, and of course the teams, to know that there is a very wide difference between screening tool and full-fledged psychodiagnostics. Psychodiagnostics, the miniature version, screening tool is a miniature version of full-form psychodiagnostics. Screening tool is a very important aspect when any patient is coming directly to any first point of contact. As I stated earlier, there would be a cutoff, and based on the cutoff, one would state that this patient needs to be sent further for whatever XYZ assessments. There are very many screening tools within India also. And of course, Dr. Swati Bajpai has developed one of them, which is the dementia assessment by rapid test, the DART. And besides that, at AIMS, we've developed other screening tools like NEST, neuropsychological assessment, um, screening tool, besides other tests also. And of course, very well known are MOCA and ACE and stuff. Yeah. But however, uh, that is exactly as I stated earlier, government is working on regulating professions. So just a tool means a psychometric tool. Whereas when I'm talking about psychodiagnostics, it is making a meaning and making sense of what the tool really states. So it is not just the test, it is the total assessment which is important to be able to even work along with the clinicians to tell what kind of a dementia is it. Is it something alarming? And also to correlate it with other factors. And that is why the multidisciplinary, the team approach, as government had recently announced, even on the 9th of this month, the team approach is the way forward.
Thank you, Dr. Nehra, for the detailed explanation. This is a very interesting question which has come. Social media use play a big role in combating loneliness. So, but there is also a fear of on-screen addiction. Older persons are also more vulnerable to eye-related issues, such as weak eyesight or a cataract. How does one balance this? That's a very interesting question.
Do you want me to take
Sure,
it?
sure.
Okay, so yes, that's certainly the case that there is quite a lot of research on social media, and it's called addiction or problematic use of problematic use. But either way, it is true that depending on the cultural context, again, we're in, social media can be a buffer against feeling of isolation and loneliness. But it can also lead to the increase of dependence, like because we feel lonely through social media, we feel less lonely, and therefore we turn again to we find a way to feel connected, we will use that more. There is evidence now emerging about AI as well and chatbots and people using chatbots and AI to offset their feelings of loneliness and depression. Can be a problem, but I think so long as it is a functional use of a tool and we are aware of it, we can control it. Self-monitoring is very important, but also making sure that we have, I always talk to my students about a toolbox. So having only one thing that together with other tools, with other things, then, for example, use social media, set up a meeting with your friends and go meet them. Yeah. So you're using it to offset your loneliness, but it's not the only way through which you connect with others.
May I come in here as well? I think a lot of the technology is not designed to actually support proper engagement in a community building, developing healthy relationships. They're actually designed for to grab our attention, right? And I think for many of us, it started on Facebook when it actually started many, many years ago. At that point, I can see a distinct difference. It did facilitate real human connection. I would go and meet people I met on Facebook already knew, but did not have a strong relationship with. And it led to me developing stronger relationships with them, friendships that I actually still have now. What has changed is how this technology has changed. And so now I get ads, I get fake profiles, I get stuff that I'm completely engaged in, but it's not leading to proper human connection. So I'm a little more reluctant to believe that people sitting on social media is leading to a reduction in loneliness. I think we're going to see an impact as we do the studies going forward that's going to show that this is not the case. And when you look at mental illness in a younger generation, and I think it's slightly different in older generation, we just don't have the studies yet. But some of what's coming out in younger generation and impact of technology on mental health because they cannot form healthy relationships, because they cannot eat healthy food because they're permanently on their phones, because they're not doing something outside or exercising. So how it's shifting habits also impacts health. And we're going to see something similar in older generation as well. And so I'm reluctant to look at its supposed advantage for loneliness. I think we need to look at how we rebuild meaningful connection, whether that's to use technology, but technology needs to be redesigned if that's what we're doing.
that's a very well said, Kirti, how, at one point of time, yes, digital is giving a lot of freedom, but at the same time, the connectivity, the friendships, the non-digital aspects are getting loose. So I think, yeah, we need a balance of all these, and specifically for the older generations, where they are actually still relied on them, and they even try a lot to get hands on the digital, but when they are not, so they are kind of underconfidence. I think we need to build certain things on these platforms, as truly said, right? So the next question is, how does digital inclusion or exclusion impact mental well-being among older adults, and what are some low cost interventions that have shown measurable success? Anyone?
I'm a cynic, so I'm going to let somebody else go first.
No, you.
Well, we talked about it in the presentation earlier on. So there are several intervention studies that have been run in different cultures, and the impact that has been the intervention is designed with focus on the specific group that we're working with, the cultural context, the social context, etc., like the study that I mentioned on digital inclusion using Germany, Thailand, and Japan as case studies. It can really help literacy, so increase the ability of people to understand the online environment and work within it, but also in terms of perceived well-being. So there are interventions that seem to suggest that digital literacy can be a solution. However, I'm very when it comes, I think it links to what Dr. Ranshod was saying before. A lot of the attempts to bring in the elderly people is really driven by a desire to tap into a market. So it's not about supporting these people, it's not about creating a more inclusive environment, it's not about well-being. They got money. So let's go and get this money. And I think that's a big problem. And if you design technology with that goal in mind, that's not going to help. We really need to be mindful. And as psychologists, I think we have a duty to be part of the process of developing these out is really designed to support rather than to tap onto an untouched market.
Thank you, Sharon. I think you're well said that, how we need to balance and how we are supposed to, create kind of an environment. Digital literacy is good, but to what end and to what platform it has to be made? That's an important thing. Just to add to this, Kirti, I have a very, I'm very curious to ask this to you that, your idea was the creativity is not limited to select few. It is something everyone can access. It plays a significant role in how we think and feel and connect with others. So I just wanted to ask, how can we encourage individuals, especially those who don't see themselves as creative, to begin engaging in such activities? That's a question that I have in my mind, so I thought I should ask you. And from a practical perspective, what are some simple creative practices that people can easily incorporate into their daily routines for brain health?
Yeah, I think I'm going to start a movement to get everyone to start drawing. But I think we do draw or we do create in different ways. And so I think that's why also I brought in the examples that I brought in, which looked at weaving, grass baskets, which looked at beadwork, making music instruments, pottery. So it does not have to be drawing the way I think of it. I do draw with a pen and paper and pencil. So art and creativity can be quite broad. I went to such a beautiful museum in Delhi, the Cultural Museum. I forget the full name of this museum in Delhi. But it was it was like a museum dedicated to cultural heritage. A small museum, but absolutely beautiful. But it was, like the containers used to store rice were just beautifully decorated by people who were living in their homes, right? The walls were painted or decorated or, patterns created on the walls. These were all traditional art forms. This is not, it wasn't learned in this formal setting. And that's what I was saying about some of these aspects that get biased when you do these tests about your brain, etc. A lot of it is taught through our family structures or community structures. And so to me, part of it, I love galleries, obviously. Teaches me to paint, right? So theoretically, I don't have any formal training. I have no formal training. But does that matter? And so I think this is what, in part, we need to shift, that what shapes the brain is what we do and how we learn. That does not necessarily have to come from formal systems. We need to value the resource and the wealth we have in what has been termed our informal systems. I'm thinking we need to redesign the word for informal systems. But yes, I think that is what I would emphasize. Like, explore your own tradition and culture, but also more broad than that. It's like mine is definitively not shaped only by mine, I think there's so much beauty in everything around us that we can learn from. And then the only advice I would give is don't be concerned about outcome. You have to just follow process, and the process is what makes this work. It's not whether you're going to be an artist or good or in a museum. Yeah.
Very well said, Kirti. I think we're running short of time, and this conversation can go on and on.
Yeah.
So, overall, has a beautiful, has beautifully brought together on multiple dimensions of brain health and aging, from understanding aging as a multidimensional and adaptive process, what Dr. Nehra said, to address the growing burden of dementia, through comprehensive care approaches, and finally empowering individuals through brain skill training and neuroplasticity by Kirti. So, and a very well concept of socio like technophobia and all these new concepts that we're learning from Sharon and Claire. So I think what clearly emerges is that healthy aging is just not about adding years to life. It's adding years, but adding your life years, I believe, through inclusive policies and relevant interventions. So I will give this to Dr. Indira for the closing remarks, and thank you so much all for being. Dr. Indira, please.
Thank you. I think after hearing, there are several take-home messages. I'm very impressed by Claire. How yeah, can be a positive influence when when it projects positive emotions, and also they found it that all the digital cultural health, a very important message. And of course, Dr. Nidra has very clearly pointed out that though some of the work is going on in dementia, we really need working models and better guidelines. And by very beautifully thought out that music resources and the community as a tool for working. Anyhow, what I say is our approach has been more and more especially preventive and then more therapy, dementia care and all that. We have to do much more about promotive and preventive. See, take, for example, the Karnataka Brain Health Initiative, a very big initiative that is started. It is a model pilot project. When you look at the report, the focus is on dementia, stroke, and epilepsy. And even the National Brain Health Program talks about prevention of addiction. Of course, these are all conditions with large disease burden. But then why don't we talk about more of mass education, mass prevention? See, for example, preventive cardiology and cardiac fitness program brought down cardiovascular surgery. Maybe it is time we talked about preventive neuroscience and brain fitness programs so that there is at a mass level, so that there is more and more involvement of public at the preventive level. And then this would be a good source to preserve the brain capital as and also they can take lessons from other countries. For example, Spain has in its brain health policy a inequality reduction component. That is a good lesson for India because it's a very rural urban gap. The Swiss plan, for example, has integrated all this AI that integrated artificial intelligence and technology program, which is also, for example, Norway has a brain health program, three prongs. At the municipality level, the health services, specialized health services, and also the third important part, the person themselves to be responsible for their brain. We can take this good the best practice and then use it, adapt it culturally, and then see how well the brain health can be. It said that there are three pillars of preserving brain health. First of all, it's the identifying the risk. It's a life force. See that you can somehow prevent this from developing. The second is boosting or reinforcing resources and resilience of people so that you get the damage. And the third is, I think the take home message is the government and policymakers that, of course, dementia is important, stroke is important, but what is important is also the brain health system at the promotive level, even for prevention completely, preventive measures and educating measures. And then beautifully, Dr. Kirti showed how using minimum resources in community, with a little bit of integrity, you can create conditions where you can handle all these issues at the community level. And ultimately, we find that in a country like India, we have to rely more on community resources, formal resources, and the care training becomes very important as Dr. indicated. So we have to look at all these models, combine them, and then extremely thankful to all the speakers today and also creating this, helping India, organizing this, all the participants. And one last message to all the participants, please translate this knowledge into practice. Take care of your brain health. I wish all of you very good brain health. Thank you all of you. Bye.
Thank you so much, ma'am, for such a wonderful remarks. And thank you, Keith, Claire, for sharing your experiences and your knowledge with us.
Can everybody please switch on their camera so that we can take a picture of this panel? Vishnu, if you could just take a picture, you also come online and just take a picture.
Anupama should be
Claire?
absolutely managed in time.
Yeah, now this looks so good. Thank you. Thank you so much.
Thank you.
Thank you. Great. Now Claire is there.
Yeah, Claire is there in the picture.
No, it wasn't. Now. Could you please click one more? Perfect. Great. Thank you.
Thank you.
Bye.
Bye-bye.
Please share the picture. I would love to have it, so I'll share it as well. And thank you. It was
Sure,
really
sure.
lovely
Sure.
discussion. Thank you.
Thank you. Bye-bye.
For their help as well. Thank you so much.